Hi, I'm Alice. I'm one of the physios here at St Bartholomew's Hospital. This video is a basic introduction aimed at non-ITU doctors into respiratory assessment and mechanical ventilation in light of the current coronavirus pandemic. So the aims of this session is to discuss respiratory assessment in basic terms for the intubated patient, to introduce you to the ventilator circuit and a basic setup, to introduce you to the ventilators we have here and the basic settings and modes of ventilation, to discuss lung protective ventilation, and finally talk about general issues and things that can go wrong. First, we're going to talk about respiratory assessment. So when you approach the bedside, it's important to have an initial discussion with the nursing staff. Ask them about their recent ventilation, whether they've been difficult or easy to ventilate, whether they've had any problems in the last few hours or overnight. Also, it's important to inquire about secretion load, whether they've been able to clear that and whether they've been coughing. Ensure that you've always got your appropriate PPE when you approach the bedside. First of all, think about looking from the end of the bed. Think about the airway that the patient has, whether that's a tracheostomy or an endotracheal tube. Assess their work of breathing and their chest wall movement, also taking note of their colour and how they look from the end of the bed. Take from the monitor the basic respiratory markers, such as your oxygen saturations, your respiratory rate, and your end tidal carbon dioxide. On approaching the patient, it's important to feel the chest wall, feel for the movement, and see if you've got equal expansion left and right. It's also really important to auscultate these patients, having a listen for breath sounds where they are present or absent or harsh, and also whether there's any additional sounds, any secretion load that can be heard. Remember to check for all patients the length of the endotracheal tube at the lips. That will also be documented on the bedside chart and is checked every shift. So we're going to talk about the basic ICU ventilator and the ventilator circuit. ICU ventilators have a double limb circuit, one expiratory and one inspiratory. You have two filters. You have one bacterial filter at the ventilator and one heat moisture exchanger, a HME. Here you attach the end tidal CO2 monitoring, which goes to the monitor at the wall. From here you have your closed circuit suction attaching to your endotracheal tube, which is cuffed. To apply your suction and suction the patient, you remove the cap from the end of the suction, attach your suction from the wall. You then need to lift and twist the cap, allowing it to be depressed. From here, you can insert the suction catheter into the endotracheal tube, apply your suction and pull out gently. You must then make sure that you lift and twist the cap again so it's no longer able to be depressed. Remove the suction and reapply your cap. It's really important in this infectious patient group to ensure that the circuit stays connected at all times and avoid any breaks in the circuit. So now we're going to introduce you to the ventilator. All pre-use checks will have been completed by the ITU team. On the front screen, on the standby screen, you need to make sure that it is an adult patient, that the ventilation type is invasive, and your ventilation mode is set to what you require. We will discuss this a little bit more in detail later. So to start the ventilator, you press and hold and tap start ventilation and start ventilation. Looking at the screen, you'll then have your mode of ventilation across the top with your three waveforms: pressure, flow and volume. On the right hand side here, we've got the modes and other things that can be manipulated. And at the bottom is one of the things most important to you. This is your 100% oxygen boost. To activate this, you press and hold, and it allows for 2 minutes of 100% oxygen. To cancel this, you just press the cross. If you required 100% oxygen for longer than 2 minutes, you can use the oxygen concentration button here and titrate it as needed. In order to do this, you press on oxygen concentration and you use the plus arrow to titrate this up to what amount of oxygen you require, in this case 100%. Once you have reached that, you use the tick to accept it. Across the bottom of the screen are all the settings which can be set. On this side of the screen, the left-hand side of the screen, is what is usually happening with the patient. These are the things that are set along the bottom and what is actually happening on the left-hand side. So the ventilator can be used in 3 main ways. So the first mode of ventilation is for your patients who are fully sedated. This would be a mandatory mode of ventilation. Here at St Bartholomew's, we use pressure control or pressure regulated volume control. This means that the ventilator is doing everything. Everything is set on the ventilator and the patient is fully sedated. Your next mode of ventilation is an interactive mode of ventilation, which here on these ventilators are known as synchronized intermittent mandatory ventilation, SIMV, and we use SIMV pressure control or SIMV pressure regulated volume control. What this mode of ventilation means is that the patient is able to interact and trigger the ventilator more. The ventilator still provides a set respiratory rate, but the patient is able to trigger their own breaths. The third mode of ventilation is a support or spontaneous mode of ventilation, such as pressure support or CPAP. In this mode of ventilation, the patient triggers all of the ventilator breaths. The ventilator is not providing those structured respiratory rate. We're going to talk in more detail about these modes shortly. It's really important to ensure that there is a lung protective ventilation strategy. This means that the tidal volume will be set at a maximum of 6 mils per kilo of predicted body weight. This will be seen on the ventilator here. It's also vitally important to make sure that the peak airway pressures do not rise above 30. This can be seen on the ventilator here. It's also important for re-recruitment of the alveoli to ensure that a high PEEP is used, and this will be set by the ICU team. This can also prevent further injury to the lung. The first mode of ventilation that we're going to talk about is pressure control. This is one of your mandatory modes of ventilation. In pressure control, you have your oxygen concentration set and your PEEP. And again, this will be set quite high by the ICU team. These are the 2 things that are going to affect your oxygenation. You've also set your pressure control, and this is above the level of your PEEP and your respiratory rate. These are the things that are going to affect your ventilation and your CO2. The other things that can be set on the ventilator, and will be done so by the ICU team, are the inspiratory to expiratory ratio, your rise time and your trigger. An inspiratory to expiratory ratio is usually set at 1:2, but this may be manipulated in certain circumstances by the ICU team. In this mode of ventilation, you will see that you get a peak airway pressure. This is the highest level of the airway pressure, and this is the P peak that we need to ensure is less than 30. Following down on this side of the ventilator, you've got your respiratory rate. This respiratory rate will match with the set respiratory rate, as the patient is in a mandatory mode of ventilation and likely to be fully sedated. Following on from here, you have your tidal volume. There are two tidal volumes on this ventilator, your expiratory tidal volume and your inspiratory tidal volume. You will see that these are very similar in number. If for any reason there is a break or a disconnection in the circuit, you will see there is a significant difference between your inspiratory and your expiratory tidal volume. For example, you'll now see that you've got a huge difference in your volumes, and the ventilator will alarm. To silence the alarm, you press the button at the top right-hand corner. So the next mode of ventilation, remaining on a mandatory mode of ventilation that we're going to talk about, is pressure regulated, volume controlled. To change the mode of ventilation, you click modes on this right-hand side. All the ventilation modes are listed here. And if in doubt on these ventilators, if you need a small description of the mode of ventilation, you can press and hold and one will appear. So PRVC stands for pressure regulated, volume controlled. In this mode of ventilation, the set parameters include your tidal volume. This mode of ventilation allows for a protective mode of ventilation to ensure that when the tidal volume set is delivered, that the peak airway pressures are not going above 30. The same as pressure control, you would be setting your oxygen concentration and your PEEP and your respiratory rate. And in this mode of ventilation, a tidal volume is set. As with pressure control, you have the same settings of your inspiratory to expiratory ratio, your rise time and your trigger. In this mode of ventilation, if the tidal volume set is exceeding your 6 mils per kilo of predicted body weight and increasing your peak airway pressures above 30, the ventilator will not deliver the breath. I'm going to demonstrate this on the ventilator now. So by increasing your tidal volume, you can see that your tidal volume of predicted body weight has increased, but also that your peak airway pressure has increased. As this peak airway pressure has exceeded the limit, the ventilator is telling you that the tidal volume breath has been restricted. And this is demonstrated here at the top of the ventilator. If in this mode of ventilation, the ventilator is continually unable to deliver the tidal volume set, the patient's ventilation will be affected. And in this case, it's important to make contact with the ICU team to adjust the ventilator settings. We'll now move to an interactive mode of ventilation, which is the next step down from your fully mandatory mode of ventilation. Again, you will use the modes button here and select an interactive mode. As I said, on these ventilators, the interactive modes are FIMV, synchronised intermittent mandatory ventilation, and these can be done in pressure control or in pressure regulated volume control. The difference with this mode of ventilation is that you have a pressure support mode, so an ability for the patient to trigger their own breath. On these modes of ventilation, you will be able to identify if the patient is triggering their own breath. If I can demonstrate this for you on the lung. As the patient triggers a breath, you will see that a white part appears on the waveform. That means that is the breath that the patient has triggered. Additionally, you will see that a small set of lungs appear here at the top of the screen. The other way in which you know that the patient is triggering breaths is to look at the respiratory rate. In this mode of ventilation, on this current settings, the respiratory rate provided by the ventilator is 15. You can see that as the patient triggers a breath, the respiratory rate on the left-hand side increases. Therefore, you can see that at present, the patient is triggering 3 breaths. The respiratory rate at 15 remains constant in this mode of ventilation. In terms of settings, it's also important to make sure that your pressure control and your pressure support are set the same. This is because you want to ensure that when the patient triggers a breath, they get the same amount of support as when the ventilator delivers a breath. And also to make sure that this remains within your lung protective strategy. So we're just going to talk briefly about FIMV PRVC. So this is one of your interactive modes. In this mode, just like in PRVC, you will have set your tidal volume to achieve that 6 mils per kilo of body weight. When the patient triggers the breath in this mode of ventilation, they receive pressure support, which ultimately creates your tidal volume. So in this mode of ventilation, it's important to ensure that your pressure support is set that when the patient triggers the breath, it's not going to exceed a tidal volume of more than 6 mils a kilo of their predicted body weight. Again, just like in other FIMV modes, you will be able to see that the patient is triggering. So the things to look for are the change of colour in the waveform, the lungs at the top of the screen, and the difference in the respiratory rate between the set respiratory rate and the respiratory rate on the left-hand side. So the final mode of ventilation that we're going to talk about is the supportive or spontaneous mode of ventilation. So this is known as pressure support. So you will see that the ventilator requires the patient to trigger the breath prior to delivering the settings. So in this mode of ventilation, the patient must trigger all of the breaths. You may find that if the patient is not breathing or stop breathing, that the patient is not yet ready for this mode of ventilation. If the patient does stop triggering the breath, the ventilator has a backup system which is set across the bottom. So it has a backup respiratory rate of 15 and with an apnea time of 20. Therefore, you can see currently that there is no patient effort. There is all flat waveforms on the ventilator. You will then see that the ventilator alarms and a breath is delivered. You can silence the alarm at the top left-hand corner. You can see across the top here that there is no patient effort. This would mean that this patient is unlikely to be ready to be on pressure support ventilation, and may need to return to an FIMV or interactive mode of ventilation. In pressure support, the patient, as I have said, triggers the breaths delivered. You still have the same settings across the bottom: your oxygen concentration, your PEEP and your pressure support, which will be set based upon the tidal volume wanting to be achieved on those lung protective strategies. So just to recap, in terms of the main points of your ventilation, a key thing that we want to ensure is lung protection and a lung protective ventilation strategy. So that is ensuring that the tidal volume is at 6 mils per kilo of predicted body weight, that your peak airway pressure remains less than 30, and both of these that you can identify the problem and call for help from the ICU team as needed, and also ensure that your PEEP remains high and in line with your adequate FiO2. It's also important to remember about your FiO2 and your 100% button to give you an opportunity to buy time where needed and get further help. We just want to touch upon some common problems that may occur. One of the things is the movement or dislodging of the endotracheal tube. It should always be checked at the length at the patient, and also make sure that this is corresponding and the same as what is documented on the ICU chart. Make sure that after any significant moving or rolling and repositioning that the tube remains at the same length as documented and was previous to the move. Other problems that can occur is a blockage of the endotracheal tube caused by secretions or plug. In this case, you'll see a large disruption to the ventilation and a likely deterioration in the patient's respiratory parameters. In order to identify this, it's important to attempt to pass a suction catheter down the endotracheal tube. As before, you will use your closed circuit suction. Make sure that it is open and feed the suction catheter down through the endotracheal tube. If there is a block, you will not be able to pass the suction catheter down. Another problem that could occur in this patient group is the incidence of a pneumothorax. This is a very serious condition and will need immediate attention. Make sure that you're using all your clinical skills to identify this pneumothorax and seek help from the ICU team immediately. So in summary, we have now covered the respiratory assessment for an intubated patient, an introduction to the ventilator circuit and the suction unit, the basic understanding and setup of the ventilator, and also the modes of ventilation. We really want to emphasise the importance of the lung protective strategy, but also to make sure that you're calling for help when needed, and the ICU team will be able to come and assist you.